Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, inflammatory bowel disease, including Crohn's disease and ulcerative colitis. Our guest is gastroenterologist Shamita Shah, an IBD specialist. First, some background. Dr. Shah received her medical degree from the LSU Health Science Center in New Orleans. That's where she did her undergraduate work, too. After finishing her general gastroenterology fellowship at Ochsner, she completed an advanced training program in inflammatory bowel disease at the University of Chicago. They take just one student a year. She spent 7 years in the San Francisco area, where she directed the inflammatory bowel disease program at prestigious Stanford University. Dr. Shah is board certified in gastroenterology and engages in cutting-edge research with a special interest, we'll find out why there's such a special interest there, in IBD-associated disease. Today she serves as the medical director for the Inflammatory Bowel Disease Program at Ochsner, and it is our pleasure to welcome Dr. Shamita Shah to Hello Health. Good to have you with us on the program, Doctor.
Thanks for having me.
Yeah, so this is one of my favorite questions, and for you it has real meaning. So who was it or what was it that first got you interested in medicine, and in your area, your specialty area of gastroenterology?
Yeah, so my father had ulcerative colitis, and so living through that as his daughter, I think with time I wanted to help more people with ulcerative colitis and Crohn's disease, and I knew I could make a difference. I felt like educationally programs like this would be great for patients so they can be owners of their own disease, and we can learn through education, all of us. And so that's really the primary reason that I went into it.
And your family is still here. You went to Ben Franklin High School and wanted to one day come back and make a difference in our community. Yeah. You and your husband, right?
Yes. I left a year after Katrina, after my fellowship, and went off and came back. And I wanted to really honestly develop an IBD program in my hometown, New Orleans, and so I'm excited to be here.
Good for you and good for us, so great to have you back. Mm-hmm. So first of all, first question, what's the difference between irritable bowel syndrome and inflammatory bowel disease?
Wow, that's a great question. I think the two get confused quite a bit. And really, irritable bowel syndrome is very different than inflammatory bowel disease. Inflammatory bowel disease includes Crohn's disease and ulcerative colitis, where people have actual inflammation in their gut. Whereas irritable bowel syndrome, if you scope patients with irritable bowel syndrome, there would be no inflammation in their gut, but it's still a real disease. And I'm sure we'll talk about it a little bit more in detail later. But IBD and IBS get confused a lot because of the acronyms, and IBD encompasses both Crohn's and ulcerative colitis.
So what is IBD?
So IBD is chronic inflammatory bowel disease of the gut, causing inflammation. It's a lifelong condition. It has periods of remission, periods of relapses, and we need medicine to kind of calm down that inflammation of the gut.
What does ulcerative colitis and Crohn's disease impact?
So it impacts pretty much anybody can get it. Definitely more common and most common between the ages of 15 and 35 years old. There is a smaller peak after the age of 50. There's really no gender predilection, meaning that men and women are both affected equally. And then certainly there is a prevalence for certain populations. So we're seeing it among Caucasians, especially higher among the American Jewish population of European descent. We are also seeing it's becoming more of a global disease. And so what I find is very interesting is that we weren't seeing in third world countries before, and now we're starting to see it. And there's a poor hygiene hypothesis where maybe as these countries began getting cleaner water supplies and westernizing their lifestyles and their diets, that they're now seeing these diseases in Africa and Asia and places like that, whereas before they were not. And so it was a North American disease many decades ago. In regards to the U.S. population, back as of 2011, there's 1.6 million Americans with this disease. By 2025, they're expecting 2.2 million. So it's certainly increasing. We don't know exactly why. We know that the number of new cases are increasing. So in the 1940s, it was 2 to 3 cases per 100,000 people. 1990s, it's now 8 to 9 cases per 100,000 people. So, and the newly diagnosed cases is what's interesting to me too, is that it's a little bit different for ulcerative colitis versus Crohn's disease, but very similar. Ulcerative colitis, you can about 7,000 to up to 46,000 new cases per year. With Crohn's, similarly, but 10,000 to 47,000 cases per year. So it's growing.
I guess these things too might be linked, but do we know what causes it?
Well, that's a very good question. So we don't know the exact cause, it's really unknown, but we do know it's an interaction between 3 things, which is genetics, immune disturbance, immune system disturbance, and the third component is environmental triggers. And when we talk about those, if I can go into a little bit more detail about those, it's not, you don't have to have a family history of ulcerative colitis or Crohn's disease. It really is a genetic predisposition. So it could just be bad genes from mom, bad genes from dad, with a certain environment, with a certain immune system. And when we talk about genetic susceptibility, family members of patients with Crohn's and colitis do have a 30 to 100 time higher risk of IBD than general population. A lot of patients of mine ask, what are the chances of my children getting this disease? And it's about 9%, siblings being affected about 9%. And then if
someone who has it already.
Someone who has it already, generation to generation. So, you know, we take care of a lot of pregnant women, and they're like, what are the chances of my kid having this? You know, that comes up quite often. And then we do see a concordance in identical twins, so more so a little bit in Crohn's disease than ulcerative colitis, and there's a lot of now genes that are associated with both of these diseases as research has advanced. Now, going back to just immune system dysregulation, the way I like to explain it is that the normal bacteria that we have in our gut, normally we're able to deal with it. But patients with this disease, they get a mucosal response, a mucosal inflammation, because the gut thinks that this bacteria is foreign. And that causes and perpetuates this mucosal inflammation because patients with IBD don't know how to downregulate that inflammation in their gut. And it's like a light switch that turns itself on and never turns itself off. And that's why we need medications to help with that. And then we'll talk a little bit about environmental triggers, just the third component of things that can cause. Well, there's things that can trigger the disease, or even your first episode or the first presentation of your disease, or a flare-up of your disease. And that can be anything from an upper respiratory infection. We often, and I think it's really important for patients to realize, and not all patients know this, is that you really need to be avoiding aspirin, Advil, Motrin, Aleve, ibuprofen, unless there's a very good reason to take them, because those taken on a regular basis can trigger the disease, just as stress. We have lots of college students that come, and during finals time, that's when they start flaring up and giving us a call, or a death in the family, or other stressors, financial stresses. Antibiotics is another thing that can trigger symptoms, as well as diet probably plays some sort of role. We don't understand everything about diet. One thing that I find super interesting is smoking. Smoking can actually worsen Crohn's disease, and then sometimes may be protective for ulcerative colitis. And I'm not advocating that ulcerative colitis patients should smoke, but there are patients that have disease onset right when they quit smoking. And those are the patients where smoking may have been protective for developing the disease. But obviously smoking has other adverse effects like heart disease and lung disease, so that sort of thing.
What about for patients who are taking a daily aspirin regimen, for example?
Yeah.
Would you recommend that they stop doing this for fear of, or should those people be tested for the propensity to have this disease, or these diseases?
Yeah, it wouldn't be the cause of their disease, but if they had the disease and they were taking a daily aspirin for cardioprotective effect, they should talk to their primary care physician, looking at risk benefits always. So I have lots of patients who have a lot of risk factors, like family history of coronary disease, high blood pressure, high cholesterol. Well, those people we're going to keep on their aspirin because it's risk benefit. We're not going to take it away from them for their ulcerative colitis or their Crohn's disease when their heart disease is more important. So it's a discussion discussion that you have with the primary care physician.
I did want to talk about, you mentioned the increasing number of cases. One thing we're hearing more and more about is probiotics and special yogurts that you can eat.
Absolutely.
That help with the gut. What is your take on all of those?
Yeah, so probiotics can be used for various gastrointestinal diseases. We can use it for irritable bowel syndrome. We use it for an infection called C. difficile colitis. Sometimes it can be used for. We use it for inflammatory bowel disease, and it depends on what disease you're talking about and the evidence based out there. In regards to IBD in particular, there are some probiotics that are better studied in a setting of IBD. And so for the most part, there's more studies and more support for ulcerative colitis than Crohn's, but it's really earlier on in disease in conjunction with standard therapy. So we don't use probiotics as a sole management tool, but we use it in conjunction with other treatments.
But for aside from these diseases, for people who might be recommended to take probiotics as a preventive measure, keep your gut healthy.
Yeah.
Where do you fall on all that from a gastroenterology standpoint?
Yeah, I mean, that's a hard one because, I mean, there's so many, there's a big market out there. And so if you're talking about evidence-based, there's not a lot of evidence-based medicine out there, but there's certainly some that are more approved for certain GI diseases, like I mentioned. I think you have to talk to your GI doctor about, you know, risk benefits and whether you need it. Sometimes it's a cost thing where the benefit is not worth it. It depends, but obviously we know that gut bacteria plays such a big role in all these GI diseases, and I think that's important to understand. And we do use probiotics in our practice for various reasons, and there are very good reasons to use it.
What's the difference between, or differences, side-by-side comparison between Crohn's disease and ulcerative colitis?
So the first thing is symptoms. So the symptoms can certainly overlap. You know, we certainly see maybe a little bit more abdominal pain seen in Crohn's disease than ulcerative colitis. Obviously, you can get diarrhea with both. Ulcerative colitis, often we'll see bloody diarrhea. Weight loss is a common feature. Fevers are another common feature, and fatigue are another common feature. Now, when you talk about how do you distinguish between the two and what the difference is, we're really looking at where the gut inflammation is and the pattern of the gut inflammation. And we're talking about when you do a colonoscopy or we do an upper endoscopy, looking for where that inflammation is and the pattern of it. So let's talk about first Crohn's disease. Really, we call it to the mouth to anus disease. It can affect anywhere in the GI tract. And not everybody, but about half of the people, about 40% of people have just the end of the small intestine and the large intestine involved. Others, 30% of people just have the small intestine involved. There's a small percentage, about a quarter of people will just have their large intestine involved. And so there's different types of Crohn's disease, and that's very important for your doctor to know from the beginning where your disease is, because we target treatments based on where the inflammation is. Whereas when we talk about ulcerative colitis is the disease of the large intestine or the colon. And the different types of ulcerative colitis depends where the inflammation is. So if it's isolated more down below in the rectum or the sigmoid colon on the left, well then we may use some topical therapy, meaning some enemas or suppositories or something to treat the disease in addition to oral treatment. If somebody has more extensive disease, about a third of people will have their entire colon involved. In that sort of situation, oral treatment may be a better way to treat the disease. So again, where the disease activity is matters on how you treat it. And so that's why it's important. And on the first visit when patients come to see me, we pull out a little map of their disease and we show them where the disease is, so we educate them on that first visit.
How do you know where the disease is? How have you determined that? And I also want to talk to you about the uncomfortableness of people talking about all these things with you. I get uncomfortable talking about all this stuff, which is bad for a guy who hosts a health show for 8 years, right?
Yeah.
But you make it very comfortable to do so.
Yeah. So I think a couple of things. I think when patients come to you, we look at all the records. I think, you know, I'm also seeing patients after sometimes they've had 20 years of disease, or maybe they've had 5 years of disease. But I think getting those past records, because that very initial colonoscopy is so important. And that's where you know where the pattern is. Now, it's also equally important to reestablish where they are now. And so depending on where their inflammation is now depends on what's going to be the next thing we do. Now, as far as patients feeling comfortable, I mean, I think it's just like this, just like I'm talking to you, we're talking to our patients and we're putting them in the driver's seat. We ask a lot of questions. It's a closed room. We have family members there if they want them to make them more comfortable. Some people don't want family members there, but I don't find that patients hold back. We ask a lot of good questions. We ask them, you know, how is this affecting your lifestyle? How is this affecting your day-to-day lifestyle? I mean, it must be hard. We'll bring up things like, hey, it must be hard that you're dealing with this and working full-time and you're a mom of 4 kids, you know? The reality is these are young patients often dealing with a difficult disease with trying to make it through life, normal life. And they haven't gotten to, some of them haven't even started life yet. I think it's harder with the younger ones. We have a lot of teenagers, 18 to 20-year-olds, and so we try to keep them with an open mind and get them to talk a little bit, and I think developing a relationship with them, so those repeated visits and kind of making them comfortable with you after the first, they meet you one time, the second time, and they meet a whole team of people. So we have 4 team members that they meet on the very first visit.
Yeah, talk to us about the whole multidisciplinary approach at Ochsner.
So a couple things. I think one is that having a good baseline team, whether it's a nurse, medical assistant, nurse practitioner, myself. We have a great team. I have Kim Guidry, Tabitha Smith, and Shannon Thomas, and we work as a team together. I think that team approach is important, but it's equally important to have a good other multidisciplinary approach. And when we talk about that, having dietitians, having good radiologists, because we're doing imaging tests such as MRIs and CAT scans to help image the upper small intestine if they have disease further up that we can't reach by scope, or looking for other things like complications like narrowings of their intestine or fistulas or abscesses, which we'll talk about later. It's equally important to have consultants. My surgeons are very important, my colon and rectal surgeons. We have a great colorectal surgery department at Ochsner, and they are also very specialized in doing inflammatory bowel disease type surgeries, which are a little bit more complicated. We'll talk about this again a little bit later too, is that the disease can affect outside of the gut. And because
what
of that—
other parts of the body? That's right. What other parts can it
Yeah,
impact?
so I mean, it can affect the eyes, it can affect the skin. You can get skin rashes and stuff related to the gut inflammation. You can get joint issues, arthritis, joint pains, kidney stones. In children, we see growth failure. So some of the adults I see now, they had it as a kid and they're a little bit more shorter statured. We see that it can affect the liver. One of my big research interests are primary sclerosing cholangitis and inflammatory bowel disease. And that's a liver condition, autoimmune condition that occurs with IBD. So this is where the multidisciplinary approach comes in again. And when I say that, I mean, you know, I rely on my ophthalmologists and my optometrists and my rheumatologists who deal with joints, as well as my dermatologist. So you have to be able to have enough consultants to help with the outside the bowel manifestations, and then we coordinate our care. So if somebody has psoriasis or psoriatic arthritis, I saw a patient today, you know, or if you have a liver disease, then we're also making sure we're coordinating our care with our hepatologist who deal with the liver disease. And so it's a very complicated disease. About 20% of people have outside the bowel manifestations of their disease, and a lot of them don't even know that it's related. A lot of times if we treat the gut inflammation, some of those will get better. Sometimes they're independent of gut inflammation. So again, but the treatment differs.
Our guest is Dr. Shamita Shah, a gastroenterologist and a specialist in the area of IBD. Tonight we're talking about inflammatory bowel disease, Crohn's disease, and ulcerative colitis. For someone with IBD, does diarrhea usually mean that the person is having a flare? Does it necessarily mean that?
That's a very good question. I think a lot of people assume that, oh, I have diarrhea, then it must be my ulcerative colitis or Crohn's disease. But it's our job as physicians to make sure that we know if it's a flare-up or not, and just not band-aid it with something like prednisone or steroids. So the very first thing that if you're really having diarrhea that we should be doing is checking some stool studies and looking for infections. One of the most common infections that we see that is C. difficile. And that is a type of, that can cause inflammation of the gut as well. And so it's really hard to know whether it's the C. diff versus their IBD flare-up, but a stool study can help with that. We also get something called bacterial overgrowth. So what bacterial overgrowth is, it's also more common in patients with narrowings of their intestine, where the bacteria in your small intestine that are normally there kind of overgrow and cause bloating and diarrhea. So that's also another thing that can cause diarrhea in a patient. It can be a medication side effect. It can be diet related. It could be irritable bowel syndrome, which we had started the program with, which is more of a sensitivity of the gut. And so by doing tests, whether it's lab tests, stool studies, scoping somebody, knowing is it a flare or is it not? And that's very important because the treatment differs for all of these things.
So what are the goals of treatment, and what are the treatment options available for people with Crohn's disease and ulcerative colitis?
So I think let's first start with the management goals. I mean, we want people to get better quickly, right? We want them to be able to do their normal, go on with their normal life, really. We want them to stay well without symptoms and without steroids. One of the worst things we can do is keep people on long-term steroids. There's long-term effects from steroids, short-term effects from steroids, but steroids are Band-Aids, as I call them. So they're great drugs when somebody's really sick, but we don't want to keep them on it long-term. And I think it's very important to achieve and maintain healing of the intestinal lining. So making sure we heal the gut from the inside and avoiding complications. We mentioned strictures, fistulas, abscesses. Those are some things that we see with Crohn's disease. Avoid hospitalizations and surgeries. There is definitely a high number of patients that undergo hospitalizations for flare-ups and other complications from their inflammatory bowel disease. And honestly, at the end of the day, just improving their quality of life so they can live a normal life.
So what is the definition of remission when we're talking about these two diseases?
So remission, a couple things. So one is, we call it total remission. And there's endoscopic remission, there is clinical remission, and there's biochemical remission. And I'll go into all of these. So endoscopic remission means that you scope them and everything's normal again. Clinical remission means they're feeling better. They're back to their normal bowel movements. They're back to their baseline. They're not having any blood. They're not having any urgency. They're having formed bowel movements again, wherever they were before. And then the last thing is we want their labs to get better. So we want their inflammatory markers back to normal. We want that they're not anemic. They're not having iron deficiency from chronic blood loss from all the inflammation. We want their vitamin levels to be healthy, that sort of thing. When we talk about management also, I think we're trying to, there's two aspects, and this is how I kind of also describe this to my fellows that I train, is that it's getting you in remission, induction of remission, and then keeping you in remission. And the induction of remission may be something like prednisone that we use. The maintenance medications are those long-term medications that keep you in remission. And so it's very important to understand that so that patients as well as the physicians who are treating them understand which drugs go into which category and how we get people in remission.
So once I've been diagnosed with the disease, am I ever cured of it, or do I always have it, but I'm in some form of remission?
Correct. So you don't get cured of the disease once you have it. It's remission based on medications. The only cure is if you had ulcerative colitis and for some reason you needed surgery and you needed your colon removed, that would be curative.
Okay. We're running short of time, but we have something very special that we want to share with our viewers. Michael Mauti played football here, I think at Mandeville High School, went on to play at Penn State, did wonderful things for Penn State, helped turn that program around during real troubled times, and he was a patient of yours and was very open about his physical and health challenges. Tell me about Michael Mauti, and then we're going to share a video with our viewers.
Sure. I met Michael Mauti back in 2015. He had seen a couple of gastroenterologists before and was struggling a little bit. So we spent a lot of time education. A lot of our visits, I was seeing him pretty often over a little over a year, trying to help him with the disease. And he had periods where he was doing well, and towards the end he wasn't doing so well, even though we had tried a lot of different medications for him. And he ended up getting surgery. and it brought him back to the playing field. We had a great surgeon by the name of Brian Can at Ochsner who operated on him and got him through his 3 surgeries, and I believe he's very grateful for the care that he received with us. But it also highlights the multidisciplinary approach that we did, and we became friends, and also a special relationship, just getting him back to the playing field and stuff, and I think he's going to share his story with us.
Here he is, Michael Mauti of the New Orleans Saints.
Well, the first thing was I was seeing blood in my stool, which it was pretty alarming, not having ever seen that in my life. And then kind of just slowly but surely a week, over the course of weeks, it's just gradually increasing. I've got to go to the bathroom and I'm running out of meetings. And then the next thing you know, I got to leave practice. Before I know it, I'm going 30 times in a day, and it's just nonstop. And that was going on for about a month, and then to the point where I just couldn't physically. I was a bag of bones. But at that point, I just knew I couldn't do it anymore. I was looking out more for my health long term because I was putting myself at risk health-wise. So that's when we, had to pull the plug on the football thing and do what was necessary. In layman's terms, they'll build you a new colon out of your small intestine. Over the course of the 3 different surgeries, about 7 months, a couple of months in between each surgery, and they say 6 months to a year is where you kind of reach your terminal capacity, or when you max out whatever you're going times per day. That's what it's going to be. But I would say I'm more than pleased with how things have gone. I mean, I've made adjustments to where it's like regular one time a day, 2 times, which is amazing, and I get to continue my football career and keep playing. It was the time that Dr. Shah took to kind of educate me, and you could just tell by her experience and her knowledge that it is really the empathy part of it to me. You could just tell that she cares about the patients, and that's something I think that's almost an intangible part of your practice. That's what makes it special.
Being a local guy, somebody you always rooted for anyway, and now there's another reason to root for Michael Mauti. I think a winner of the recipient of the Ed Block Courage Award, voted by his teammates, an NFL award given every year, I think, per team for sportsmanship, courage, and inspiration. He certainly checks all those boxes, doesn't he?
Yeah, he sure does.
Yeah, for him to share his story. So wonderful. Well, Doctor, thank you for your work at Ochsner, for the education you provided tonight, and for moving back home to be with us, and for helping patients, and certainly an inspiring story. Thank you so much.
Thank you so much.
Dr. Shamita Shah, I want to thank her again for everything she's provided, the education tonight, and for her work in the Ochsner Health System. Well, still coming up, to make an appointment with any Ochsner physician, including tonight's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at a program set up just for viewers of this program. And you can register for any of Ochsner's Hello Health seminars here, too, at the number on your screen. You can also send us questions by email, hellohealth@ochsner.org. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on Ochsner's website at ochsner.org. Just type Hello Health in the search areas and that'll get you started. Our thanks again to tonight's guests. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and our station. We'll see you next time.